Good day, everyone. I'm Giovanni Di Peri. I'm talking from Torino, northwestern Italy. Here is 6 p.m. and have the privilege to co-chair with Professor David Beck this session 2 abstract session of the International Workshop of Clinical Pharmacology of HIV, hepatitis, and other antiviral drug. So unusual conditions, I would say, but everything so far so good, it's working properly. So it's my pleasure to introduce the first speaker, who is Dr. Jenna Yeager, is a postdoctoral fellow at the University of Colorado. She's going to present the contribution about steady-state plasma tenofovir FTC among adolescent transgender men and women receiving directly observed daily TDF FTC. Please, Dr. Yeager.
Hello, my name is Jenna Yeager. I'm a fellow at the University of Colorado. Today I'll be presenting on steady-state plasma tenofovir and emtricitabine among adolescent transgender men and transgender women receiving directly observed daily TDF FTC. I have no conflicts of interest to disclose. Briefly, to provide a little bit of background, transgender persons are more vulnerable to HIV infection. Specifically, here in the US, the estimated prevalence among transgender persons is about 9%, compared to less than 0.5% in the general population. And even though we're aware of this increased vulnerability, transgender individuals tend to be underrepresented in oral PrEP trials, with transgender men having been excluded from these clinical trials, and transgender women typically being grouped with cisgender men who have sex with men. For example, in the PrEP trial, only about 14% of participants were transgender women, and in the Discover trial, only about 1 to 2% of participants were transgender women. One concern with having such limited data in this population is whether or not there's a drug-drug interaction that exists between hormone therapy and PrEP. Recently, a few pharmacokinetic studies have aimed to address whether or not this interaction exists. On the right-hand side here, you can see that some of these studies did find lower concentrations of either tenofovir or emtricitabine in plasma, and then others found no difference in concentration either in plasma or PBMC. So overall, the data does still remain limited in this population, especially among adolescent transgender individuals and transgender men. Therefore, the objective of this study, the TransPrEP study, is to assess whether the use of cross-sex hormone therapy altered the pharmacokinetics of tenofovir disoproxyl fumarate, or TDF, in combination with emtricitabine among adolescent transgender men and transgender women. So looking at the overall study design for the TransPrEP study, it was conducted among HIV uninfected transgender men and transgender women. They were adolescents aged 15 to 24 years, and they did have to be on a stable hormone dose for at least 1 month prior to enrollment, as well as being willing to maintain that same dose throughout the study period. The results of the TransPrEP study were then compared to historical cisgender controls from the CellPrEP study, which was a population of HIV uninfected adults aged 18 to 55. These studies were similarly designed. Both were prospective observational PK studies, where participants received daily TDF FTC for about a month. Intensive PK sampling in both studies was performed under fasting conditions. In the TransPrEP study, this was done after about 2 to 3 weeks of daily TDF FTC dosing, and in the CellPrEP study, this was done after about 30 days. For TransPrEP, dosing was directly observed, whereas in the CellPrEP study, adherence to daily TDF FTC was assessed by other methods, such as pill count, self-report, and a dosing calendar. PK parameters were calculated using non-compartmental methods and log transformed. These results were then compared to cisgender controls from the CellPrEP study using a 2-sample t-test. So looking overall at the study populations, for trans PrEP and cell PrEP studies, you can see that 47 trans PrEP participants were included in this analysis, 24 transgender women and 23 transgender men. In cell PrEP, there were 19 participants, 10 cisgender women and 9 cisgender men. Because trans PrEP was conducted among adolescents specifically, the age was younger in this group compared to cell PrEP participants. For creatinine clearance, this was calculated using Cockcroft-Gault for all participants in trans PrEP who are above the age of 18, as well as all cell PrEP participants. For those under the age of 18 in the trans PrEP study, their creatinine clearance was calculated using the Schwartz equation. And then looking at the route of administration for hormones in the trans PrEP study, 50% of transgender women were receiving oral or sublingual estradiol, and 50% were receiving intramuscular. Among transgender men, the majority were receiving testosterone intramuscularly, and the remaining 20% were receiving it via subcutaneous route. So now looking at plasma tenofovir concentrations among the trans PrEP population, here on the left, you'll see average plasma tenofovir concentrations at each of the sampling time points for transgender women in blue and transgender men in orange. And then on the right here, we're comparing the geometric mean values for these PK parameters among transgender women to transgender men. And you can see that overall plasma tenofovir PK was similar between these two groups. On the left, you can now see average plasma tenofovir concentrations at each sampling time point for cell PrEP participants in black. And then on the right, comparing transgender women to cell PrEP participants, you can see that transgender women had significantly higher trough concentrations. However, overall exposures to plasma tenofovir were the same between the two. And then if we compare transgender men to cell PrEP participants, you'll see that tenofovir AUC was higher among transgender men compared to cell PrEP participants. Here, this graph is showing us the individual AUC values for all participants. Transgender women are in blue, transgender men in orange, and cell PrEP participants in black. This gray shaded area in the background represents the range of median or geometric mean AUCs that were reported for comparator groups from previous PK studies among transgender women. Now looking at plasma emtricitabine PK, you can see in this graph on the left the average emtricitabine concentrations at each sampling time point for transgender women in blue and transgender men in orange. And then if we compare the PK in these two groups here in this table on the right, you'll see that transgender men had higher peak concentrations as well as higher emtricitabine AUC compared to transgender women. On the left here, you can now also see the average emtricitabine concentrations at each sampling point for cell PrEP participants in black. And then this table on the right is comparing the geometric mean PK parameters among transgender women to those cell PrEP participants. And you can see that overall, these two groups were pretty similar. If we then compare transgender men to cell PrEP participants, we again see that transgender men have higher peak concentrations and higher emtricitabine AUC compared to those cell PrEP participants. Similar to the graph that was shown previously for tenofovir, this graph shows individual plasma emtricitabine AUCs for each participant. We have transgender women in blue, transgender men in orange, and cell PrEP participants in black. And again, that shaded area in the background represents median or geometric mean AUCs of the comparator groups or control groups from previous PK studies that were conducted among transgender women. In conclusion, we did see adolescent transgender women had similar tenofovir and emtricitabine exposures compared to historical controls from the cell PrEP study. However, transgender men had higher emtricitabine exposures compared to transgender women and compared to cell prep participants. The mechanism for this isn't clear at this time. Overall, both tenofovir and emtricitabine exposures were similar to concentrations that have been seen in control groups of previous studies among transgender women. And based on this, daily TDF-FTC PrEP should continue to be recommended for transgender adolescents who are at risk of HIV infection. I just wanted to thank the study participants, the members of the Colorado Antiviral Pharmacology Lab, the staff at both Stroger Hospital of Cook County and Children's Hospital of Colorado for their work on this project, and the National Institute of Mental Health for funding it.
Okay, thank you, Dr. Yeager, for your interesting presentation. Now I invite Mrs. Letitia Najimba, who is statistician at the Infectious Disease Institute in Kampala, Uganda, who's going to present the abstract entitled Plasma and Breast Milk Pharmacokinetics of Tenofovir using dried blood and breast milk spots in HIV-infected postpartum women in Uganda. Please, Dr. Najimba.
Thank you so much for giving me this opportunity to present to you this work. My name is Letitia Najimba. I'm a statistician at the Infectious Disease Institute, Kampala, Uganda. Today I'll be taking you through maternal blood and breast milk pharmacokinetics of tenofovir using dried blood and breast milk spots in HIV-infected postpartum women in Uganda. To give you an introduction and background of our study, approximately 1.5 million HIV-infected women worldwide become pregnant each year. Given that breastfeeding remains the only acceptable and safe infant feeding option in low and middle income countries, the risk of mother-to-child transmission of HIV is particularly high when untreated women enter care later in pregnancy, that is more than 28 weeks. Breast milk transfer of first-line ART from mother to infant is not fully understood, and HIV-positive infected women are prescribed ARVs to prevent perinatal transmission of HIV and to optimize maternal health. Despite tenofovir being part of many first-line regimens, the transfer from mother to breastfed infant in the early postpartum period has not been described in detail. With all that in mind, it gave us our objective to develop a population pharmacokinetic model describing tenofovir concentrations in maternal blood and breast milk using dried blood and breast milk spots in HIV-infected postpartum women in Uganda. To explain our study design and PK sampling, the study took place at the Infectious Disease Institute in Kampala, Uganda, and it included pregnant women who are 18 years and above, who are 32 weeks pregnant or more than 32 weeks, that is 1 to 2 weeks postpartum, receiving a recommended combination ARV regimen. Pharmacokinetic samples were obtained on maternal blood, that is dried blood spots, and breast milk, that is dried breast milk spots. And moving forward, I will be calling dried blood spots DBS and dried breast milk spots DBMS. DBS and DBMS samples were collected at 5 to 6 time points up to the 12th hour following observed dosing on 2 out of 3 postpartum occasions, that is at week 1 to 2, 4 to 6 weeks, and 10 to 12 weeks. To explain our population pharmacokinetic modeling, Our maternal model, that is the dried blood spot and breast milk, was designed under the non-mem version 7.3, and we tested a 1 and 2 compartment model for the maternal blood. We also tested a compartmental model versus a ratio model for the breast milk, that is under our structure model. We tested different covariates under our covariate model, such as weight, occasion, maternal age, among others. And then we plotted our final diagnostics, which included the visual predictive check, goodness of fit plots, among other plots. We also have to note that all infant samples were below limit of quantification, and our blood low limit of quantification was 16.6 nanograms per milliliter, and our breast milk low limit of quantification was 4.2 nanograms per milliliter. To explain our population characteristics and demographics, our study had a total number of 26 study participants who had a median age of 29 years, with a median weight of 64 kilograms, median CD4 count of 598 copies. Our study participants had a median weight of 56 kilograms at the second PK visit. TFV blood pharmacokinetics were best described by a 1 compartment first order absorption model, and breast milk concentrations were modeled as a constant ratio of blood exposure. Following multivariate analysis, weight was the only significant covariate to remain in the model. Weight was modeled as an effect on clearance by allometric scaling, with exponent fixed to 0.74. Our clearance parameter estimate was 104 liters per hour, with inter-individual variability of 9.7%. We had a distribution of 1,500 liters, with an inter-individual variability of 86.1%. We had an absorption rate constant per oral of 5.66, and our breast milk ratio constant, the KBM, was 0.093. This is the VPC plot of the raw data of the study overlaid with the prediction fittings, and this VPC shows that our fit of the model to the data is consistent. We are doing further refinements on the breast milk model to improve the description of breast milk profile for the 1st to the 8th hour, as well as removing outliers of concentrations at the 12th hour in the blood profile. With that, we conclude that intensive data collection allowed estimation of pharmacokinetics of tenofovir in dried blood and breast milk spots, and we also note that tenofovir concentrations are low in breast milk as compared to maternal blood when using blood and breast milk spots, with weight as a significant covariate on clearance. I would like to acknowledge our study team and participants. These are photos of our study nurses, as well as people who are part of our study team. I would also want to acknowledge the Wellcome Trust for funding this study, University of Liverpool, as well as the Infectious Disease Institute. Thank you.
Thank you very much, Dr. Najimba. Now the third presentation by Dr. Christina Brooks, who is research assistant professor at the University of Colorado Skaggs School of Pharmacy and Pharmaceutical Sciences, who is going to present time course of tenofovir diphosphate carryover in red blood spots following TDF to TAF switch. Please, Christina.
Thank you to the conference organizers for the opportunity to present these results. Today, I will be presenting on the time course of tenofovir diphosphate carryover in dry blood spots following TDF to TAF switch. I have no disclosures to make. Tenofovir diphosphate in DBS is an important tool for assessing adherence to TDF and TAF-based therapy. It's reflective of cumulative dosing over the previous 2 to 3 months owing to its long half-life of 17 to 20 days in red blood cells. It also demonstrates strong relationships with clinical outcomes in persons on PrEP and persons with HIV. Tenofovir diphosphate levels are approximately 10-fold higher with TDF in comparison to TAF in red blood cells. This results in the need to assay differing DBS punch sizes, as shown in the figure on the right, where for TDF we assay a 3 mm punch size in comparison to TAF, where we assay a 2 by 7 mm punch size. Ultimately, this results in us being able to achieve similar dynamic ranges of tenofovir diphosphate, as shown in the table on the right. However, assaying larger punch sizes may amplify residual tenofovir diphosphate from TDF in persons switching to TAF. The objective of these analyses were to characterize tenofovir diphosphate carryover in DBS following TDF to TAF switch. The DBS samples used in these analyses came from a study where we were comparing the plasma and intracellular pharmacokinetics and renal safety of TAF, boosted PIs, and ledipasvir sofosbuvir in persons with HIV. A total of 10 people were enrolled. Adherence was monitored using wise pill devices throughout the study. In phase 1, participants continued their TDF with a boosted PI for 12 weeks. In phase 2, they switched to TAF 25 milligrams with a boosted PI for an additional 12 weeks. In phase 3, we added on ledipasvir sofosbuvir for a period of 4 weeks. And in phase 4, they resumed taking TAF 25 milligrams with a boosted PI for an additional 12 weeks. Blood was collected at the end of each phase, including DBS. Tenofovir diphosphate was quantified using LCMS methods. For TDF, we assayed 1 by 3 millimeter and 2 by 7 millimeter punch sizes, and for TAF, we assayed 2 by 7 millimeter punch sizes. In order to probe the potential influence of residual tenofovir diphosphate remaining from TDF, we calculated the amount of tenofovir diphosphate remaining from the 2 by 7 millimeter punch size by taking the concentration that was measured at the end of phase 1 in participants on TDF, and then for the elimination rate constant, we used a value that corresponded to the median IQR half-life of 17 or 15 to 20 days from previous TDF studies that have been conducted. And for time, it was time post-TDF switch in relation to when the PK assessments took place in remaining phases of the study. We then took that amount residual that was calculated and then divided that by the amount of tenofovir diphosphate that was measured throughout the remaining TAF phases. Here I'm showing you the tenofovir diphosphate concentrations in DBS across the various study phases. I first want to call your attention to the TDF results. So these concentrations reflect the 3 millimeter punch size that we generally use. You can see that in comparison to the 2 by 7 millimeter punch sizes that were used to assay TAF, overall the concentrations are generally comparable for the differing punch sizes with the 2 different prodrugs. Where we started to think that tenofovir diphosphate carryover might be an issue is that if you assay the 2 by 7 millimeter punch sizes for TDF, the results are approximately 14-fold higher in comparison to the 3 millimeter punch size with TDF, as shown with the red dots. So when you do the initial comparison of TDF against TAF between phases 1 and 2, the TAF results, they were 81% lower when comparing the same 2 by 7 millimeter punch sizes. But then what we noticed is that between phases 2 and 3, results were 11% lower, and between phase 2 and 4, the DBS concentrations were 15% lower after controlling for adherence. So you can see that the tenofovir diphosphate concentrations continued to decline following the TAF switch. On this slide, I'm showing you the decay of residual tenofovir diphosphate with TDF from the 2 by 7 millimeter punch size. The x-axis at time 0, this is corresponding to the day that the TDF to TAF switch occurred. So in this example, we're starting from the minimum value that was measured with TDF with the 2 by 7 millimeter punch sizes for the DBS. And you can see that 4 to 5 half-lives later, visually in comparison to where it started, it doesn't look like too much is remaining. But even with that 3 to 6% that you'd estimate for the 4 to 5 half-lives later, assuming a half-life of 17 to 20 days, you could still potentially measure 388 femtomoles per 2 by 7 millimeter punches from that residual tenofovir diphosphate from the TDF, again, from the 2 by 7 millimeter punch size. Again, this is showing this similar concept of the decay of residual tenofovir diphosphate with TDF, again with a 2 by 7 millimeter punch size. Again, day 0 corresponds to TDF to TAF switch, but in this case, we're starting at the maximum value that was measured in a participant with TDF with that 2 by 7 millimeter punch size. And again, using that similar concept of around 3 to 6% remaining, approximately 4 to 5 half-lives later, you can see that that amount would correspond to a measurement of 2,942 femtomoles per 2 by 7 millimeter punch size. Again, in this case, assuming a 20-day half-life or more of the extreme of the upper bounds that have been measured in previous studies. Here I'm showing you overlays of the residual tenofovir diphosphate remaining from TDF relative to the TAF-DBS concentrations that were being measured across the different study phases. So the lines reflect the residual tenofovir diphosphate remaining from TDF with the 2 by 7 millimeter punch size, and the bars and lines reflect the geometric mean 95% confidence interval measured in each of the TAF phases. So for these gray lines, these reflect the minimum, geometric mean, and maximum tenofovir diphosphate concentrations that were measured with TDF in phase 1, again assuming a half-life of 17 days in these cases. And you can see with the overlays that depending on where people are starting in this specific study, that the residual tenofovir diphosphate could potentially be accounting for anywhere between a geometric mean of 17 and range of 9 to 34% of what's being measured in TAF-DBS in phase 2. And again, this was 12 weeks after that initial TDF switch. In phase 3, this was 4 weeks after the phase 2 assessment. The residual tenofovir diphosphate levels remaining were lower. Again, though, there's a range of potentially 3 to 11% of what's being measured in TAF at that phase could potentially be due to residual tenofovir diphosphate from TDF. In phase 4, which was 12 weeks after the phase 3 assessment, you can see that at this point, there's very little residual tenofovir diphosphate remaining from TDF relative to TAF. Assuming a 20-day half-life, which again was the 75th percentile of what's been measured in previous studies with TDF, you can see that the residual amount remaining in this case, again a bit more of an extreme, it falls below 5% relative to the TAF-DBS levels that are being measured approximately 22 weeks post-switch. So in conclusion, carryover of TDF to TAF switch may significantly affect DBS adherence interpretations. The contribution of residual tenofovir diphosphate from TDF depends on the time frame of assessment and levels at the time of switch. Among those was steady state and good adherence. In this study, the impact of residual tenofovir diphosphate is negligible approximately 5 months post-TDF to TAF switch. So researchers and clinical providers should wait at least 5 months after switching from TDF to TAF for comparisons of tenofovir diphosphate against adherence gradients. And with that, I'd like to thank the study participants, members of the Colorado Antiviral Pharmacology Laboratory, our statisticians in the School of Public Health, our collaborators at Denver Health, and also clinical staff at the CTRC, and also Gilead for funding this study in addition to NIDA.
Okay, this is now time for question and answers about. So we already received a couple of questions from the audience. There's question one for Dr. Jaeger. The question is whether a difference in time to therapeutic concentrations in transgender women versus transgender men versus cell prep. Did you get the question?
Yes. So we actually only looked at the steady state plasma concentrations at this point. So we don't actually have the time to steady state or the time to those therapeutic concentrations. We did see trough levels across all 3 groups that were above those 40 nanograms per milliliter concentrations. that are associated with protective efficacy.
Okay, there's a second question for you, Dr. Jäger. For plasma PK parameters, did you consider normalizing for body weight?
So we did see slight differences in body weight, but because this is an ongoing analysis, we didn't control for it. Those transgender men in the TransPrep study had lower median body weights compared to the transgender woman and the cell prep participants. So that is something that we'll control for in the future, and hopefully will account for some of that difference that we're seeing.
Okay. A further question for you. Were there differences in FTC concentration among TGM participants receiving delivery of testosterone by intramuscular injection compared to oral dosing?
Yes, so all of the transgender men were receiving testosterone by parenteral route, so either intramuscular or subcutaneous, and the majority were intramuscular.
Okay, but you didn't note any particular differences in FTC concentrations according to the route of administration?
No, we didn't notice any difference in that group according to route of administration, and those results aren't here right now, but we do have those too that we're going to look into further later on.
Okay, no further questions from the audience. Now, I have a question for Letitia. Maybe I missed the point, but my question is, there were other antiretrovirals administered in these women. I mean, whether taking already antiretroviral therapy, I would assume yes, looking at the CD4 cell count you've shown in your slide. So is there any influence according to the concurrent antiretroviral or even other drugs that women were taking at the same time on the same period?
Yes, thank you so much. Yeah, there were other regimens, we're receiving other regimens, some people on Lopinava, and this is something we are still looking at to discover more and to give more information in our paper. Thank you.
Okay. Now, from the audience, there's a question for Christina Brooks. I read, I got confused on how you accounted for the circulating tenofovir PP from TAF during your analysis for tenofovir PP from TDF in your dried blood spots. I can read again, it's a long question actually. So I got confused on how you accounted for the circulating tenofovir from TAF during your analysis for tenofovir from TDF in your DBS.
Yeah, so for the TAF phases, right, so that was in phases 2, 3, and 4, after they had switched to TDF, those TAF tenofovir diphosphate levels were based on what was actually measured from that 2x7 millimeter punch size at each of those time points. So that's how we came up with what was being measured across each of those TAF phases. The overlays I was showing was just essentially adjusting the half-life estimate from the TDF decay between 17 and 20 days, and also from the extremes of what was being measured in phase 1 from when participants were still on TDF. So I'm not sure too if part of the confusion is figuring out how much was actually coming from each amount across each of these participants. We don't actually have an answer to that. We tried to give kind of a perspective on the range of values that could come up based on what we were actually measuring in dry blood spots across each of those time points.
Okay, there's a question coming for Letitia Najimba. And how applicable is your approach for other drugs like PIs, dolutegravir, etc.? Which are the main technical barriers?
Yes, and there is a study in Malawi doing the same with DTG, and we are yet to find out their results and how they will go with that. And for the barriers, I would say let us still wait for the study to see what they experience. However, for TFV, apart from experiencing low levels, low concentrations in the infants, more barriers will still come up. We have to find out from the DTG. Thank you.
Okay, can I ask you, Letitia, what about the storage temperature for your dried blood spots? I mean, from breast milk, is there any indication? Can you just keep them there at room temperature, 25 degrees, or I don't know, just a very basic question.
Yes, our spots were stored not at room temperature, but they were in a freezer, and they were then transferred at that same temperature within a freezer till we did our analysis. I
see. But this is what you did. But my question might be, I mean, if you put your samples, which are I imagine on a card in an envelope, and you send by regular mail somewhere in the world, when their arrival are still good for analysis, or you believe these samples will be deteriorated?
As they were transferred, they were still maintained within a freezer to another area. So they maintain the temperature.
Okay,
yes.
sorry. Okay.
Maybe I could ask a question, Gianni.
Yes.
Could I just ask a question of Jenna? I mean, you said in your abstract, and also you said in the talk, the differences, mechanism unclear at this point. I mean, it's relatively minor differences, I guess 20%, but mechanism unclear. I mean, you must have discussed the potential mechanism. What are your thoughts around the mechanism of the differences?
Sure. So my main thought might be the relation to body weight that was asked about earlier. So that's something that we need to look into a little more. Otherwise, not really sure at this point. It looks like the elimination phase is pretty similar for the two. The Cmax is definitely higher, but we know that emtricitabine is almost completely absorbed regularly. So increased absorption probably isn't playing much of a role here either. So I think the next step will be to look at body weight and see how much that's impacting things.
Okay.
I have a question for Christina Brooks. Please, Christina. I mean, in one of your first slides, you have shown that a lot of turnover is entrapped inside the red blood cells. Is it true? Yes. Okay. Now, I wonder whether, yes, if a patient is recovering from an acute infection, he was anemic, he's producing a lot of fresh red blood cells, but usually we calculate an average life of 120 days. Might this change what you're going to find in your samples if you have very, lively renewal of red blood cells?
Yeah, absolutely. And this is kind of something our lab is starting to dive into further a little bit. It's just looking at the, I guess, like all the different sources that could potentially affect declining levels of tenofovir diphosphate. We know a lot of the demographic factors that lead to whatever steady state concentrations, and know there's differences between like men and women and white versus black race. But in terms of looking at the biologic factors like red blood cell turnover or other enzymatic differences between people and how that could affect how quickly levels decline, that's something that we're actively working on.
And an extreme scenario in very anemic patients, I mean, 5 milligram of hemoglobin, are we expected to find less tenofovir plasma because these reservoirs are less numerous?
In terms of if we'd expect levels to be lower, I would definitely say yes, just based on relationships that we understand at this point. But obviously in that situation too, is probably a little bit more critical needs for other.
Now, I imagine, an African scenario when someone is recovering from malaria, has very low hemoglobin levels. So just to understand. Okay.
Yeah, it's a very good question. Yep.
And Christina, can I ask you a question, Christina, about, I'm sure I've discussed this with members of your team before, but in terms of why dried blood spot tenofovir diphosphate is so much higher after TDF, when in lymphocytes, it's TAF gives you a higher concentration of the diphosphate in lymphocytes. So what's the main driving mechanism? I know we've discussed it before, but can you just remind me again of the difference?
Yeah, I mean, I will caution we don't fully know, because this question always comes up of whether or not how much it is of either the disoproxil or the TAF, like the alafenamide feeding into cells versus tenofovir as the parent form versus the intermediates.
Yeah.
And that's something too that we're actively looking into and needs to be addressed. But one potential consideration is that tenofovir levels, if those are feeding into the red blood cells, there's a 10-fold difference. Right, so with TDF, it's 10-fold higher in comparison to TAF. So that's one potential mechanism. But we still need to look more so into the prodrugs and intermediates feeding into those as well, and how those can explain the cell-specific differences that we've noticed.
Mm-hmm.
Could be, David, that there is no carboxyexterase on red blood cells. So if you get a staph, almost all the drug goes to lymphocytes and pathocytes, and no such a wide variety of cells.
Right.
Could be. Okay.
Could I ask a question of Letitia? It's just really a practical question, and again, I may have discussed this with Katrina Waite, but different times postpartum, the constituents of the milk is going to be different. So how does this practically affect the dried milk spots? Or, have you looked at how different times postpartum there may be differences in milk constituents and how that might impact?
Yes, this we really discussed, and we considered a correlation factor, and this is something we're going to add when we are doing our paper finally. But we want to consider a correlation factor as stated by some writer called Zeng et al. And I want to consider that also in our writing.
Okay. Thank you.
Okay. I think we have still a couple of minutes left for discussion, but if there are no more questions, may I leave to David Beck the conclusions of this session and the introduction to the next one?
Okay, well, thank you very much to everyone who was on that first part of the session. I think, in my experience, this part of the meeting is always one of the most relevant parts, because we're reviewing really up-to-date data and really up-to-date research. And I think we've had 3 talks which have really given us a great example of some of the quality research that is being done in different areas. And I think that's very important. So maybe we could just move, to the next session, which is going to be the poster abstracts. Okay, so these are the best poster presenter abstracts. So we've got 4 presentations very quickly. So they're going to be 5-minute presentations. And then we're just going to spend a couple of minutes on each presentation, hopefully 8 minutes or so just in discussion at the end. So we've got 4 presentations: Mackenzie Cottrell from UNC Chapel Hill, and then Fazila Bonglawala from the pharmacology department at Liverpool University, Justin Jones, also from UNC Chapel Hill, and then Michael Ferreira from the ID unit, University of Torino in Italy. So we have 4 presentations, one after the other, and then we'll have some Q&A. So thank you. We'll go into the first of those presentations.
Thank you to the conference organizers for allowing me to present these data on behalf of my co-authors. I have no conflicts of interest to disclose. Better characterization of PrEP pharmacology and HIV transmission sites within understudied populations of transgender women and non-binary individuals is needed to better understand PrEP's effectiveness in these high-risk populations. However, the resource-intensive processing procedures associated with isolating HIV target cells from tissue biopsies makes these studies very difficult to conduct. We sought to determine whether collecting rectal epithelial cells via cytobrush might offer a simpler alternative by which to study PrEP pharmacology in transmission sites, Through determining whether concentrations of PrEP's active metabolites and competing endogenous nucleotides were correlated between rectal epithelial cells and rectal CD4 cells, as well as identifying the impact of female sex hormones on this relationship. To this aim, we enrolled 10 healthy premenopausal cisgender females with regular menstrual cycles who utilized contraceptive methods that permit menses on a monthly basis. Participants took 5 directly observed doses of tenofovir disoproxil fumarate with emtricitabine prior to 2 sampling visits that were scheduled to coincide with their early follicular phase, where estradiol is expected to be low, and their late follicular phase, where estradiol is expected to be at its peak. We performed phlebotomy to collect blood serum and endoscopy to collect cytobrush scrapings and rectal tissue biopsies at both visits. We collected epithelial cells from the cytobrush by washing in PBS and isolated CD4 cells from the tissue biopsies by enzymatic digestion and immunomagnetic positive selection. Cells were then counted and lysed in 70-30 methanol water. Estradiol and progesterone were quantified in serum by specific enzyme immunoassay, and PrEP's active metabolites and competing endogenous nucleotides were quantified in cell lysate by HPLC-MS-MS. These resulting concentrations were normalized to cell count and reported in femtomole per million cell unit. The demographic characteristics of our study sample are provided at the bottom of this slide for your reference. Here I'm showing estradiol concentrations on the y-axis by cycle day on the x-axis for each study participant. Their method of birth control is categorized by color. Those using abstinence, condoms, or female-only partners are in pink. Those using 21+7 combined oral hormonal contraception are in blue, and 2 participants using a non-hormonal IUD and a NuvaRing are in black. The median cycle day associated with our first visit was 5, and with our second visit was 15. You can see that for most participants, serum estradiol increases as would be expected as they approach ovulation. Likewise, here you can see that serum progesterone concentrations also increase in most participants as they approach the luteal phase of their menstrual cycle, where progesterone is at its peak. In this graph, I'm showing rectal CD4 tenofovir diphosphate concentrations on the x-axis and those measured in rectal epithelial cells on the y-axis. Blue triangles indicate data points that were collected during the early follicular phase, and pink circles are those that were collected during the late follicular phase. We observed approximately 18-fold higher tenofovir diphosphate concentrations in rectal CD4 cells when compared to rectal epithelial cells, with no correlation between the 2 matrices within or across menstrual cycle phase. For emtricitabine triphosphate, concentrations were approximately 300-fold higher in rectal CD4 cells compared to rectal epithelial cells, and there was no correlation between the 2 matrices. For DATP, or deoxyadenosine triphosphate, concentrations were approximately 10-fold higher and not correlated. And finally, for deoxycytidine triphosphate, concentrations were approximately 10-fold higher and also not correlated. Interestingly, we observed significantly lower tenofovir diphosphate concentrations in rectal CD4 cells when measured during the late follicular phase, shown in this graph as paired concentration data plotted on the y-axis with visit on the x-axis for each participant. These tenofovir diphosphate concentrations were not correlated with estradiol or progesterone, suggesting an indirect mechanism of interaction. Because the late follicular phase coincides with the window of vulnerability when the female genital tract is at a heightened risk of acquiring HIV, further investigation is needed to determine if this decrease is also observed in CD4 cells collected from the female genital tract. Our findings demonstrate that these nucleotide concentrations are consistently lower in rectal epithelial cells when compared to rectal CD4 cells and are not correlated between the 2 matrices within or across menstrual cycle phase. Unfortunately, the lack of correlation demonstrates that rectal epithelial cells collected by cytobrush should not be used as a surrogate for HIV target cells within HIV transmission sites in studies that are intended to characterize PrEP's pharmacology. With that, I'd like to thank my funding sources and the study participants, as well as acknowledge the exceptional efforts of our friend Heather Prince in executing this trial. Thank you.
thank you to the organising committee for giving me the opportunity to present my research here today. Lymphoid tissues are a primary site of HIV replication. Antiretroviral therapy results in the effective inhibition of viral replication in peripheral blood. However, HIV reservoirs can persist in tissues. Continuing viral replication has previously been linked with subtherapeutic concentrations of antiretroviral drugs in the lymphoid tissues, and lymphoid tissues can represent a reservoir of inducible virus. Understanding the degree in which antiretrovirals penetrate lymphoid tissues could be pivotal in optimizing therapy and reducing the latent reservoir. The objective of this study was to incorporate lymphatic physiology in a whole-body physiologically based pharmacokinetic model to describe the penetration of antiretrovirals in lymphoid tissues. A generic schematic of the PPK model can be seen in the diagram on the right, where individual organs are represented as single tissue compartments, which are connected by the cardiovascular system. The lymphatic PPK model was created from a previously published adult PPK model. Specifically for the lymphatic model, each compartment was further divided into a vascular, interstitial, and tissue compartment to better characterize drug movement and has been illustrated in the diagram. The model is set up such that the arterial blood compartment receives blood from the lung compartment and distributes blood to all vascular compartments. Each vascular compartment is connected to its respective tissue and interstitial fluid compartment. Lymph flow-driven drug movement from the tissue compartment to the interstitial fluid compartments was also included. Lymph from all the organs is delivered to a central lymph node compartment via the efferent lymph supply from the interstitial compartments. Lymph flow is then delivered to the renal compartment from the lymph node, completing the circuit. Parameters such as lymphatic flow, interstitial fluid, and vascular capacities were used to describe the physiology of the lymphatic system and were derived from the literature. Moving on to the validation, the PPK model was qualified against available literature data describing the lymphatic tissue to plasma penetration ratios of raltegravir and efavirenz. Physical, chemical, and biological characteristics such as log-P, pKa, and intrinsic clearances were utilized as input data to simulate the plasma PK profile of both drugs. Certain drug-specific parameters such as fraction unbound in plasma and fraction unbound in tissue and blood-to-plasma ratios were used to determine lymphatic penetration. 100 healthy patients were simulated over a 30-day period for both drugs, and mean PK parameters were recorded for comparison and have been detailed in the table. Efavirenz 600 mg once daily and raltegravir 400 mg twice daily were simulated, with mean AUC, Cmax, and Ctrough values yielding absolute average fold error values well within the twofold acceptance criteria. Moving on to the prediction of lymphatic penetration, the graph on the left describes the average daily concentrations of both drugs in plasma and lymph, and on the right we have the penetration ratios. The observed lymph-to-plasma penetration ratios of raltegravir and efavirenz were reported as 1.49 and 2.28. In comparison, the simulated ratio for raltegravir was 1.42 and for efavirenz 1.97. As you can see, the model is in good agreement with literature values and can appropriately describe the penetration of raltegravir and efavirenz. To summarize, quantifying antiretrovirals in lymphoid tissues can help optimize antiviral activity. The lymphatic model shown here today can be particularly useful when coupled to a pharmacodynamic model describing viral kinetics and can generate information that can be used as input data for such PD models. This kind of coupled mechanistic modeling technique can be used to develop new antiretroviral dosing regimens that strategically target the HIV reservoir, marking the foundation for working towards a potential cure. Lastly, I'd like to say thank you to the members of my research group at the University of Liverpool.
Thank you to the conference organizers for allowing me to present our data on behalf of my co-authors. I have no conflicts of interest to disclose. EFdA is a potent nucleoside reverse transcriptase translocation inhibitor, which exhibits favorable pharmacokinetic characteristics for long-acting formulation and has been investigated in a drug-eluting implant for HIV pre-exposure prophylaxis. EFdA is intracellularly phosphorylated and inhibits HIV integration via multiple mechanisms, including immediate or delayed chain termination following EFdA triphosphate's incorporation into the nascent DNA strand in place of the endogenous nucleotide DATP. Thus, the validity of preclinical safety and efficacy assessments relies on the assumption that EFdA's intracellular pharmacology is consistent across species. We hypothesized that EFdA was differentially phosphorylated among species commonly used for preclinical models in drug development, with a goal to identify which preclinical models most closely match the intracellular pharmacology of humans. We isolated peripheral blood mononuclear cells from whole blood of 6 species via phi-col separation and using a red blood cell lysis. We incubated 1 million live PBMCs in 0, 5, 50, or 500 nanograms per mil EFdA in triplicate for 24 hours under standard culture conditions. We then removed the treated media, washed with PBS, and counted PBMCs in a representative control well on a hemocytometer using trypan blue staining to characterize viability. PBMCs were then lysed in 70-30 methanol water. EFdA triphosphate and DATP were quantified by HPLC, MSMS, and resulting concentrations were reported in F moles per million live cell units based on the representative count. All species exhibited cellular viability above 87% at 24 hours of culture, except for rabbit, which was approximately 34%. I'm showing EFdA triphosphate concentrations plotted on the y-axis across dosing levels on the x-axis for human PBMCs, which have been quantified across 3 dosing levels. Non-human primates and rat also exhibited quantifiable concentrations across all 3 dosing levels, but were approximately 1.8 to 15-fold lower than humans, respectively. Natural log transformed EFdA concentrations increased particularly with natural log dosing. In these 3 species with R-squared values above 0.7. Additionally, human and non-human primates exhibit the most similar relationship between concentration and dose, with a linear regression line slopes of 0.89 and 0.85 respectively. For mini pig, we were able to quantify EFdA triphosphate concentrations at the 50 and 500 dosing levels that were approximately 46-fold lower than human. For dog and rabbit, we were only able to quantify EFdA triphosphate concentrations at the highest dosing level that were approximately 110 and 780-fold lower than human, respectively. Here, I'm showing DATP concentrations plotted on the y-axis, grouped by species on the x-axis. The lines through these box plots are the median. Box edges are 25 and 75th percentile, and the whiskers are 10th and 90th percentile. Non-human primate, mini pig, and dog DATP concentrations were significantly higher by 2 to 10-fold when compared to humans, while rat was significantly lower by 4-fold. We did not make this comparison for rabbit due to the poor cellular viability after 24 hours. We found that EFdA's intracellular pharmacology significantly differed between species. While the degree of phosphorylation was most similar between non-human primates and humans, EFdA's computing nucleotide DATP was approximately 10-fold higher in non-human primate, which could result in lower potency when compared to humans. While EFdA triphosphate concentrations alone were lower in rat, the relationship between the EFdA triphosphate and DATP was more similar to humans. Given these rat data, similar studies should be conducted in mice to determine whether humanized mice might be the optimal efficacy model for EFdA. One limitation of our study is that we only explored EFdA triphosphate and did not characterize intermediary compounds such as EFdA monophosphate, because structural activity relationship studies between EFdA monophosphate may be pharmacologically active. This more complete characterization is warranted. I'd like to acknowledge my funding sources listed here, and I'm happy to take any questions.
Good evening to everyone, and it's a pleasure for me to present our work at the International Workshop on Clinical Pharmacology, from the title Inflammation Effects, Antiretroviral Plasma and Intracellular Exposure. Starting from the fact that the aim of antiretroviral therapy is to maintain a virological suppression in our patients and to promote immune recovery. We all know that most of the drug targets are at the intracellular level, but yet the association of intracellular concentrations with the efficacy and tolerability of the regimens is not completely known. So some authors previously showed that during chronic inflammation, there is a higher expression of some membrane transporters, such as glycoprotein P or organic anion transporters. And additionally, these lower intracellular penetrations within PBMCs or tissues have been observed with this higher expression of these transporters. So the group of Fletcher showed that limited penetrations of antiretroviral drugs within tissue brings to the persistence of the immune sanctuaries as a potential mechanism of viral persistence and chronic inflammation too. So for that reason, aim of our study was to investigate the correlations between the plasma presence of inflammation biomarkers and the plasma and intracellular exposure of some of antiretroviral drugs in our HIV positive population. For that reason, we included in our study 60 adult patients on a stable heart and all virological suppressed at the time of the analysis. Most of them were male, 80%, with a median age of 53 years old and a normal BMI. We divided in 3 groups, 25 on a triple therapy and a dolutegravir as the third drug, 9 on a dolutegravir-based dual therapy, plus the protease inhibitors such as darunavir and atazanavir boosted with cobicistat, and 26 patients as the third group on the triple therapy and the darunavir cobicistat as the third drug. We measured 4 different inflammatory biomarkers such as CRP, interleukin-6, CD14 and LPS, and we compared in the 3 groups. We performed the correlation at last between these inflammation biomarkers and antiretroviral drug plasma and intracellular concentrations. As you can see in the table, there were no difference among the 3 groups of these 4 inflammation biomarkers. As far as concerned the correlations between the antiretroviral drug, plasma, and intracellular exposures with the 4 different inflammation biomarkers, they are reported in the table above, where we did not observe any statistically significant correlations between the dolutegravir intracellular plasma or intracellular plasma ratio. But if you look at the darunavir plasma correlations, we found a positive correlations that tend to be significant with the CD14 as reported in the graph on the left, and the inverse correlations statistically significant between the darunavir intracellular plasma ratio and interleukin-6 as reported in the graph on the right. But we wanted to study the dolutegravir concentrations when dosed with the boosted therapy on the dual therapy as reported here in the first column versus the dolutegravir dosed in the unboosted regimen dosed with the triple therapy. And we found correlation and inverse correlations between dolutegravir in the unboosted regimen that tend to be significant with the CD14. And as you can see in the graph on the left, in the boosted regimen, there was no correlation at all with the CD14. So to conclude, we observed a lower darunavir and the dolutegravir in the unboosted regimen intracellular penetrations, together with a higher expression of some inflammation biomarkers. So our data support the hypothesis of a concrete interplay between a chronic inflammation and the antiretroviral penetrations within PBMCs. The molecular mechanism need to be further studied. They are not still clarified. But to understand the effect of a chronic inflammation and the penetrations within tissues within PBMC or the modern antiretroviral therapy can be very important and relevant for the choice of a correct antiretroviral regimen, can be even included in the immunomodulating strategies. And with this, I want to thank all my collaborators and you for the attention.
So great. Thank you very much indeed to the 4 presenters. There's one question at the moment. It says to Dr. Cottrell, but I suspect it's not to you, Mackenzie. I think it's to Justin. The question is, why is this relevant to the use of EFdA for PrEP in humans? So I think that's to Justin, as to what is the relevance of the species difference to PrEP in humans? Or maybe, Mackenzie, you want to take it because it was addressed to you. But
yeah, I'm happy to take it for Justin. since both of these were kind of my posters with me on the lead. So really what we were trying to do with this study was answer the question of what's the right preclinical model to study EFdA for long-acting formulations of PrEP. And so what you risk if you have a preclinical model that the intracellular pharmacology doesn't match humans is coming out with efficacy or toxicity findings from that preclinical model that can't be recapitulated in humans. And so while I recognize that EFdA is being studied currently in humans and that our data demonstrate that humans are actually the best case scenario for EFdA's pharmacology, we're really trying to inform the field about if you're studying a long-acting implant, what is the best preclinical species to select that will most closely match that of humans. So I think that answers why we did this study.
Yeah, and there's one more question, which again, I don't know whether maybe you want to take this, which is there any efficacy data for EFdA in preclinical models like SIV, SHIV, challenge studies to support the PrEP claim?
I think that there's some forthcoming efficacy data in SIV, SHIV challenge studies. I believe that some very limited efficacy data has also been published in abstract form, excuse me. What's been published in manuscript form, to my knowledge to date, has primarily focused on the pharmacokinetics of long-actings and exploring how long we can keep EFdA going for from these implants.
So I think that's the questions we have from the audience. So Professor DePerry, it's up to you and I to make sure that we have questions. Do you have any specific questions? I have a couple for each of the presenters.
I would like to
have a question, Professor
yes,
DePerry?
About EFdA. I mean, is the clearance of the drug, which is so slow in as far as we know in humans, is that proportionally shorter in the animal models were described? I mean, it does apply also to clearance of the different in pharmacokinetic, intracellular pharmacokinetics. I mean, differences in dephosphorylation or something. I don't know.
Sure. So our study was simply an in vitro study where we dosed cells with it and looked at 24 hours at EFdA triphosphate concentrations. We know from in vivo preclinical PK studies that the clearance of EFdA is faster in mouse and non-human primate than it is in human, which is somewhat expected based on standard allometric scaling models. What we don't know is there a dephosphorylation mechanism that acts more quickly in these animal models? I can't answer that in the in vivo space. I can't parse out, based on our study design, what was an inability of the animal cell to phosphorylate versus what was the animal cell dephosphorylating more quickly. We dosed and then checked EFdA triphosphate at 24 hours and didn't really dive into which part of the pathway is altered from humans. But certainly for the parent compound in plasma, we know that clearance is faster in the smaller mammals.
Okay.
Maybe I could ask a question to Justin, which would sort of parallel, and then we can go to a couple of. Justin, we had some discussion earlier in the day about remdesivir, which is an adenosine analog. Do you know about any information at all which would parallel the kind of work you've done with the FDA in species differences? Has that been done with remdesivir, another adenosine analog, for example?
I wouldn't be particularly privy to that.
Right. Okay. Mackenzie, do you know any data on remdesivir?
I'm not aware of anything to date. I think that our lab was over the summer expecting to measure some remdesivir triphosphate concentrations, but then we didn't end up getting the sample sent to us. So I can't speak from anything that we've done personally, and I haven't seen anything in the published literature about it yet.
Okay. Let me just check. I think there was a
question for Mikol Ferrara, I think.
There's a question for Mikol, but I've lost it. Have you got it there, Gianni?
Yes, okay, I'm going to read it. Mikol Ferrara, do you think that the lower IC concentrations in persistent inflammation are clinically relevant or not?
We actually don't know that. Actually, our patients were at a low, completely, so they were controlled, virological controlled. So we don't know in the long term. We just studied our patients at a baseline. We have maybe to check the viral load in a long term, but actually we just know the baseline. So I don't know. The plasma concentrations were very good actually, because they are very similar to the one reported in literature. In the Liverpool website or in other papers. So the plasma concentrations was very good. So the viral load was undetectable in all the patients.
Okay, can I just take advantage? I mean, talking about intracellular concentration, a question to Fazila, who has studied the issue. I'm very interested, I mean, penetration into lymphoid organs. It is very fascinating compartment. I mean, according to you, I mean, what are your thoughts about possibility to increase the penetration of drugs into lymphoid organs?
Yeah, so one of the reasons we did this was to kind of then have the further application of optimizing antiretroviral therapy to maximize concentrations in those tissues. So hopefully an application of this is to then kind of couple it to a pharmacodynamic model, which helps us evaluate not only the tissue concentrations, but then the resulting effect of the viral kinetics of that. So hopefully a future kind of study for this would be to evaluate potential regimens and maximize concentrations in lymphoid tissues.
Yes, now I think please remember those findings about lymph node fibrosis that were, I mean, reducing the passage of drugs, also a sort of cirrhosis of the lymph node, which looks important for the distribution of drugs there. Thank you very much.
Yes. And Fazila, can I ask you a question? What sort of limitations, all models seem to have limitations to some extent. What are the limitations of your current model? Is there anything not included that you can actually get further information and then include it to make the model a little bit more, in the next stage?
Yeah, so I think when we first started this project, it became apparent that although there's several antiretrovirals that have been studied in various lymphoid tissues in humans, the data available is still lacking. And then the confirmatory studies of that data is also lacking. So it makes it really difficult to kind of have that precision and accuracy of the recorded values, which we then use to kind of validate the model. And then when you do find studies that have used the same drugs and looked at penetration in lymphoid tissues, the methodologies are sometimes different, which makes it hard to kind of compare between the two and interpret the data. And then in terms of things that we could include, so transporter expression is something that we haven't looked into yet. But again, when it comes to trying to interpret the data and representing that quantitatively into the model, it becomes a lot more difficult. So yeah, it's difficult to kind of find a solution to these because of the lack of data that's available. But that being said, the model is under constant refinement. So the more data that's out there, the more we can use to refine the model, and it helps the predictions of new drugs that we can then simulate and look at penetration into the lymphoid tissues.
Thank you. Yeah, thank you very much. We're going to finish. I've got one very quick question and one quick answer from Mikol in terms of panels of biomarkers. I mean, do you think that we've yet got a coherent answer to which biomarkers are better to look at, or are we on a learning curve for this?
Yes, it's totally learning field. It's very, very fascinating. But I haven't seen any difference in the. Have you seen in my presentation? There were no markers that actually can have maybe interleukin 6 or the CD14. I've seen some correlation, but I cannot tell which one is the best. We can tell that for sure they have maybe an impact on the expression of these protein transporters, and because all the studies have been performed in vitro. But the very fascinating field is to study with these concentrations, this field in vivo. So with the concentrations, we can have a better understanding of this. Indirectly, we can see the effect of these protein transporters. So I don't know which one is the best to answer to your question, actually.
Well, there's plenty of work to be done. So thank you, everybody, very, very much indeed to Mackenzie, Fazila, Justin, Mikol. And on behalf of Professor DePerry and myself, we draw this first day's session, session 1 and session 2, to a close. I think it's been really, really an exciting program.